Hello, my name is Paul Friedman. I'm chair of the Department of Cardiovascular Medicine at Mayo Clinic in Rochester, and I'm delighted to be joined by my colleagues today. I have with me Dr. Katie Young, who's an assistant professor of medicine and is the cardiology director of the Cardio Obstetrics Clinic. Dr. Young, thank you for joining me.
Thank you. Happy to be here today.
And I'm also delighted to be joined by my colleague, Dr. Abhishek Deshmukh, who is a cardiac electrophysiologist, director of the ECG and Physiologic Monitoring Lab, and who has an interest also in OB and arrhythmia. So, Abhishek, thank you for joining me.
Many thanks. Excited to be here.
So let's start, first of all, with some of the foundational issues around arrhythmias in pregnancy. First of all, what are the primary risk factors for developing arrhythmias in pregnancy?
I will say as a whole, palpitations is a very common pregnancy-related concern or patient concern through pregnancy. And we know that arrhythmias are the most common cardiac complication for women with known cardiac disease. So this will be encountered in your practice and is very common. Major risk factors for arrhythmias in pregnancy are primarily related to pre-existing structural disease, maybe someone with congenital heart disease or other valve abnormalities or cardiomyopathy. So those would be where we see most of these occur. Other risk factors, though, do include women who have pregnancy at later ages, so advanced maternal age, obesity, and then those that have a high prevalence of other comorbidities such as hypertension, diabetes. Those all increase their risk of having arrhythmias in pregnancy as well.
Now, Dr. Deshmukh, in your paper, there was a dramatic increase over roughly a decade of more than 50% in the frequency of arrhythmias. Why do you think that is?
So, we had looked at the overall hospitalizations related to arrhythmias in pregnant women. And initially, the traditional teaching was always that SPTs is probably going to be the most common arrhythmia noted in pregnancy. But what we have seen over the last few decades, as the maternal age has gone up, as patients have more comorbidities, specifically hypertension or obesity, that can set up triggers to set off other arrhythmias. And more commonly, what we have seen is atrial fibrillation. And that kind of mirrors a general population right now because atrial fibrillation is so common. And if you think of pregnancy, it's a perfect setup to have atrial fibrillation in patients who are at a higher risk. You need a trigger, which could be coming from the pulmonary veins, but more importantly, the autonomic modulators, the higher sympathetic tone, slightly higher resting heart rate, could potentially set up a perfect scenario that you could have atrial fibrillation. A lot of these patients had atrial fibrillation before, so pregnancy just adds one more layer of a risk factor for them to have atrial fibrillation during pregnancy. And that's one of the reasons why we are seeing more atrial fibrillation. But nowadays, as you know, you don't need a doctor to diagnose atrial fibrillation. A lot of our patients have smart watches, and that will also pick up atrial fibrillation. And that also kind of tunes in that why the overall prevalence of some of these arrhythmias are increasing.
No, that makes a ton of sense. Now, Dr. Young, you mentioned that palpitations are very common in pregnancy. Mm-hmm. And so for women who don't have known heart disease, for example, and they complain of palpitations, when do you suggest we need additional evaluation to see whether arrhythmias are present? And what would be a logical next step for a pregnant woman with palpitations? And what are some of the key points in the history you want to pin down so that you say, oh, this is benign versus this needs more looking into?
Yeah, that's a great question because this, as I mentioned, will be a very common kind of concern that comes up in your clinical practice. And first, I would say is that many women are symptomatic simply from the increase in heart rate that is normal in pregnancy. So the resting heart rate increases sometimes up to 20-25% compared to their pre-pregnancy heart rate. And in some women, that's enough for them to just have a sensation of palpitations or noting their heartbeat. So in many patients, it may be benign. I think the basic evaluation to start with, though, is obtaining a 12-lead ECG. And then Then it kind of depends on the frequency of symptoms. If someone is having daily symptoms, I think starting with a simple 24-hour Holter is reasonable. If their symptoms are more infrequent, maybe they monitor with their home watch. I've done that, or a cardia device, or maybe we do more prolonged rhythm monitoring. But things I'm looking for are history of structural heart disease, of course, history of pre-syncope, syncope, notable family history of perhaps any kind of early onset heart disease or arrhythmias. And then you'll get more information from their baseline ECG. If that's pretty normal, that's reassuring. But then from all of that, and after I've met with the patient and listened to them, I use that concern. If I'm more concerned for underlying cardiac disease, because remember, many women will present during pregnancy as these hemodynamic and physiologic changes may unmask cardiac disease. So I have a fairly low threshold to obtain a baseline structural evaluation with an echo. If I do find any atrial fibrillation, SVT, other arrhythmia, to screen them so I can better counsel them and provide treatment recommendations.
One area that may be more of a future-looking direction, but we're seeing some emerging data is on the use of AI ECGs to screen. And maybe Dr. Deshmukh is head of our ECG lab. What are your thoughts or comments on the information we have? What is it, the AI ECG? What might it or might it not do in pregnancy?
No, great question. So, AI ECG will be great not only for cardiac, but even non-cardiac things. So, for example, a lot of our patients are at a risk for having preeclampsia, hypertension during pregnancy. So, if, maybe an ECG can predict who would be at a risk for having adverse fetal and maternal outcomes. But from specific arrhythmia standpoint, I think it is, very ripe as, with all your pioneering work, that if it can predict if patient has had silent atrial fibrillation or undetected atrial fibrillation, or risk of low ejection fraction, then at least it can be a good screening tool also to find out who will be at a higher risk during their pregnancy. And I'm aware some of our colleagues have done some amazing work on that.
Yeah, no, there have been some publications from colleagues with interest in that space. But moving to more the concrete now and today, suppose a woman who's pregnant presents with a racing heartbeat in the emergency room. Maybe she has atrial fibrillation or SVT. Do you cardiovert? And if so, what are the special considerations?
Great. So I think if a patient presents with SVT and based on the ECG, we are convinced this is a narrow complex regular tachycardia and she is stable, I think definitely adenosine can be given in pregnancy. It is pretty safe, very rapid mechanism of action, and at least it can be a good diagnostic and a therapeutic option to treat and terminate some of the SVTs. But if a patient is coming with atrial fibrillation with rapid rates, it really depends on how the patient is doing. If it is hemodynamically tolerated, we can consider beta blockers, and typically the beta blockers of choice would be propranolol or metoprolol. Digoxin has been around forever, and that can be tried to control the heart rate from the rate standpoint. And cardioversion is safe as long as the patient we rule out a presence of a clot in the left atrial appendage. Cardioversion can be safely performed, and we always wonder whether the fetus will be at a risk with that that energy which is delivered. And it turns out it is not, because people have studied umbilical cord velocities and there have been no significant change in velocities. The fetus myocardium has a very high defibrillation threshold, so that energy wouldn't get conducted to the fetus to cause any adverse event or adverse outcomes to the fetus. But at least it should be done in a controlled environment where fetal monitoring is present, where cardioversion can be performed safely and effectively to terminate some of these arrhythmias. And to prevent them from going into AFib again and again, we need to find a good antiarrhythmic solution for them. And sotalol has been studied extensively, and it's very safe to consider during a pregnancy. Flecainide can also be considered. So either flecainide or sotalol can be considered to see if we can reduce the AFib burden during pregnancy.
What about blood thinning, Dr. Young, pregnant women and anticoagulation, either for women with arrhythmias? It also comes up, obviously, in women with mechanical valves.
Right.
Comments on that?
Yeah, so I would say in terms of, I think this is another, when we talk about future areas to study, this is another area that definitely needs to be investigated. There's not a lot of data on the use of anticoagulation for isolated atrial fibrillation in pregnancy. We know that Chad's VAS score is not validated in pregnancy, though in our clinical practice, we use those same risk factors to risk stratify our patients for anticoagulation. However, pregnancy itself is also a hypercoagulable state, so that also needs to be accounted for. So this is definitely a shared decision-making discussion with patients. So number one, if they have a cardioversion, you absolutely would need to anticoagulate them for 4 weeks afterwards. And what we would typically use would be low molecular weight heparin, just because you will not have that baseline or know kind of what their warfarin dose may be. And remember that DOACs are not currently safe to use in pregnancy. There's no safety data for pregnancy or breastfeeding. So that is not an option. Then I look to, see, do we know if they have structural heart disease? So someone with structural heart disease, let's say they have particularly rheumatic mitral stenosis, they automatically get anticoagulated with atrial fibrillation. And then other, congenital heart disease, advanced cardiomyopathies and such, you may also tend to favor anticoagulation for pregnancy and after, just given that structural disease. But we do have patients that have normal hearts and they have some cardiac risk factors and they develop AFib in pregnancy. And that really becomes a discussion with the patient. And I think in part also depends on the burden of their atrial fibrillation. If they had one brief episode versus ongoing persistent AFib, that may also push me to more strongly recommend anticoagulation.
Now, a question that comes up not very frequently, but can certainly be hand-wringing is, are there times when we should consider an ablation procedure in a pregnant woman? And Abhishek, what would be circumstances that might drive that decision? And, under what circumstances would you consider doing that?
Yeah, so a great question. So, ablation, there have been several reports of ablation being done during pregnancy. And really depends on what kind of arrhythmia we are treating and what is the expected anticipated outcome. Having said that, nowadays with the mapping systems being so good that we can potentially aim to do a zero fluoroscopy procedure. So if a patient is having recurrent AVNRTs causing hemodynamic instability, or patient is having rapid atrial flutters, that potentially can be treated by ablation. I mean, from my anecdote of one of my lifetime greatest case, there was a PVC triggered VF in a patient with pregnancy, which we mapped and ablated. And I mean, just imagine somebody going into VF again and again. Fortunately, that patient had a defibrillator and that was, ablated and she did well. But, those we need to have a lot of planning going on behind that with all the, maternal fetal medicine experts, anesthesia, everything else.
It just reminds me that often the best way to take good care of the fetus is to take good care of the mom, whether it's ablation or cardioversion or, whatever is medically appropriate. And Dr. Young, you co-direct a multidisciplinary team that manages arrhythmias as well as other cardiovascular conditions during pregnancy. What specialists are typically involved? Tell us about that team and its role in care and who should be seen by that team.
Yeah, absolutely. So this is, in the field of cardiology, cardiobstetrics is really growing as a field and as a subspecialty even within cardiology itself. And the cardiobstetrics team, or you may hear the term pregnancy heart team, is really designed to help coordinate care for these patients that have many needs from many disciplines. And so the mainstay of the team is a cardiologist who feels comfortable managing cardiac disease in pregnancy, along with maternal fetal medicine specialists. And in addition to that, we work very closely with OB anesthesia, occasionally our cardiac anesthesia colleagues, pharmacy, social work, our nurses, nurse practitioners, physician assistants that help us see these patients. And then that really makes the core. And then depending on the needs of the patient, we involve other cardiac subspecialties. So, I reach out to Abhishek for someone who has a rhythm concern. Maybe we reach out to someone in pulmonary hypertension or our interventional colleagues. It really then depends on what the patient needs are. And really, we should really be seeing patients even before pregnancy, if possible, for someone with congenital heart disease or other known arrhythmias or cardiac structural disease, having them receive preconception counseling through the pregnancy heart team is very beneficial. And let's say someone who does have AFib or an SVT, particular to this topic, having that ablation prior to pregnancy if necessary, or making a treatment plan for antiarrhythmics is very beneficial so that everyone's on board and has a solid treatment plan. And then we follow patients through pregnancy, their deliveries, and then postpartum is important as well. And really just making sure they have a good treatment plan, followed closely, and kind of feel comfortable that they're receiving care from individuals who have knowledge and experience in treating cardiac disease in pregnancy.
That makes a lot of sense, especially with the growing body of evidence showing that preeclampsia and eclampsia have long-term impacts on hypertension and cardiovascular risk.
Yes, absolutely.
And kind of following up on that, Dr. Deshmukh, what are the gaps in knowledge and emerging research directions that you see in the space of arrhythmias in pregnancy?
So I think the most important thing, we need to still identify who will be at a risk to get that arrhythmia event during pregnancy, and whether that arrhythmia event is going to be detrimental for maternal and fetal outcomes. So that part is unclear because, a lot of people could have a little bit of fleeting AFib, but how much of that AFib is going to cause hemodynamic consequence, say maybe during labor and delivery, is something which is unknown. But apart from that, we need to understand a little bit better about medical management, anticoagulation, role of DOACs, role of wearable defibrillators in patients with higher risk of sudden cardiac death during pregnancy, how to manage certain congenital heart disease patients with risk for pregnancy, risk of arrhythmias, channelopathies, all those things. We still need to have more understanding and knowledge. But I think as we get better in taking care of patients who are not pregnant with these conditions, I think we are going to translate that knowledge in that pregnancy arena too now.
And maybe one last question on Dr. Young, I'll turn to you for this one. And that is, there's been a brief discussion around Apple Watches, but there are a growing number of home OB monitoring tools. Some are ultrasound devices like a hockey puck that a expectant mother can use on herself at home, or a family member can use. Some are wearable abdominal ECG recording bands that can potentially record on the baby's health. What is the status of that practice now? When do you use these kinds of devices? And looking into your crystal ball, what do you see happening in the near-term future?
So that's exciting to that we have all these potential options to help manage our patients better. I think in our current practice, the things we're utilizing most commonly are probably wearable rhythm monitoring or heart rate monitoring devices. We do a lot of remote blood pressure monitoring as well in these patients, particularly those that have pre-existing hypertension or those with preeclampsia and postpartum, where you're following them very closely. So those are avenues, I think, where these ambulatory monitors are being used pretty routinely already. And I absolutely think there could be a role to use more of this, particularly in the cardio OB space. This is a time where you're watching both mom and baby. So any tools that allow you to do that and monitor people from home and maybe help you provide access to care for individuals that live further away from centers. I think that's one of the main kind of benefits that I could see for many of our patients that live further away, and we could help provide monitoring and counseling from a further distance, which would be great.
Well, it's a remarkable space, and given the millions of women who are pregnant every year, even a small percentage impacted by this is a lot of people. And obviously, a special, unique characteristic in this space is that you have two young patients, the expectant mom and her baby. So really a terribly important space. Exciting to see the progress being made. And thank you, Dr. Young, Dr. Deshmukh, for your leadership in this space and for sharing your knowledge with us today.
Thanks a lot.
Yes, thank you very much.